Welcome, everyone. Today we're going to start talking about the heart, one of the most vital organs in the human body. In this lesson, we'll introduce you to the anatomy of the heart, explore how it functions as a dual pump, and understand its essential role in maintaining life through circulation. This topic lays the foundation for understanding the entire cardiovascular system, so be sure to take note of both structural details and functional concepts as we move forward. Before we dive into the details, let's take a look at the learning objectives for this chapter. These objectives highlight the key concepts and competencies you should develop. We'll begin with the basic anatomy of the heart, its size, shape, and position in the thoracic cavity. Then we'll move into identifying the internal chambers and valves, as well as the major vessels associated with the heart. We'll examine how blood flows through the heart in two separate circuits, the pulmonary and systemic, and discuss the mechanical phases of the cardiac cycle, systole and diastole, in both the atria and the ventricles. We'll also learn how the cardiac conduction system regulates heartbeat and how we can assess that using the electrocardiogram or ECG. Finally, we'll wrap up the overview of fetal heart development, which provides context for congenital heart conditions and early cardiovascular function. The heart is often described as a double pump because it operates two major circuits at the same time. The right side of the heart pumps blood to the lungs via the pulmonary circuit, where it picks up oxygen and releases carbon dioxide. The left side sends oxygen-rich blood through the systemic circuit to supply the tissues and organs of the body. Despite being called a pump, the heart is not made up of metal and valves. It's living, dynamic muscle made primarily of cardiac muscle tissue. It contracts rhythmically, involuntarily, and tirelessly throughout our lives. The terminology we use, cardiac, for example, comes from the Latin word cardia, meaning heart. Understanding its origin helps us make sense of medical terms. Finally, the field of cardiology is dedicated to the study of the heart and its diseases. Specialists in this field are known as cardiologists. As we proceed, keep in mind that we are learning its biological basis for both normal function and potential clinical issues. Let's begin by examining the position and orientation of the heart within the body. The human heart is located in the thoracic cavity, more specifically in the central region called the mediastinum, which is the area between the two lungs. This region also houses the vital structures such as the trachea, esophagus, and major blood vessels. The heart is enclosed in a double-layer sac called the pericardium, which not only holds the heart in place but also provides physical protection and limits movement during the cardiac cycle. The pericardial cavity between the two layers of the pericardium is filled with a serous fluid that reduces friction as the heart beats. Anatomically, the heart is asymmetrical in position. The apex, or the pointed end of the heart, is tilted slightly to the left and rests just above the diaphragm between the junction of the fourth and fifth ribs. This is also the landmark where you can palpate the apical heartbeat and where stethoscope placement is ideal for listening to the mitral valves. The base, which includes the great vessels, is positioned near the second and third costal cartilages and lies more posteriorly. Due to the rotated orientation of the heart, the right side of the heart sits more anteriorly and the left side of the heart is more posterior. This rotation is important to remember when reading imaging studies or performing physical examinations. Additionally, the left lung has more noticeable indentations known as the cardiac notch, which accommodates the position of the heart's apex. Understanding this orientation is also vital for emergency procedures like cardiopulmonary resuscitation, because the heart lies just beneath the sternum and anterior to the vertebra. Compressions performed in the correct spot in the sternum can help circulate blood during cardiac arrest. All of the anatomical details, orientations, landmarks, and nearby structures are essential knowledge for both diagnostic assessment and emergency intervention. The heart's position in the thorax is not just important for anatomy exams. It's critical importance in real life, especially during emergency situations. Because the heart lies directly behind the sternum and in front of the vertebral column, it can be physically compressed between these two structures. That's the basic principle behind cardiopulmonary resuscitation, or CPR. When someone's heart stops beating, chest compressions can manually pump blood through the heart and into the pulmonary and systemic circuits, at least temporarily. Proper hand placement is key. The heel of one hand should be placed on the middle of the chest, just above the xiphoid process of the sternum, specifically about 2 finger widths above it. Compression should be performed at a rate of 100 to 120 per minute. Ironically, the beat of the Bee Gees song Staying Alive is perfect reference, and the depth at about 5 centimeters in adults. Now, while CPR can save lives, is not without risk. Incorrect placement or overly forceful compressions can lead to broken ribs or a fractured sternum, or even damage to the internal organs like the liver, especially if pressure is applied directly over the xiphoid process. This is why CPR training and certifications are also important, not just for healthcare professionals, but for anyone who may be first on the scene of an emergency. The key takeaway here is the heart's anatomical position allows CPR to work, not only if performed correctly. This reinforces why knowing surface anatomy is more than theoretical. It's practical and sometimes life-saving. When we picture the heart, most of us imagine a classic symbol from Valentine's Day, but the real heart is shaped more like a pine cone or an upside-down cone. It has a broad superior base where the major vessels connect and a narrow inferior apex, which points downwards and slightly to the left. In terms of dimensions, a typical adult heart is about 12 centimeters long, 8 centimeters wide, and 6 centimeters thick, roughly the size of your closed fist. It weighs between 250 and 350 grams, depending on factors like body size, sex, and especially physical activity level. One fascinating aspect of the heart's anatomy is how it can adapt to physical activity. For example, well-trained endurance athletes often develop physiological hypertrophy of the heart. Their cardiac muscle cells grow larger, not in number but in size, allowing the heart to pump more blood with each beat. This is why athletes often have lower resting heart rates. Their heart rates are more efficient. However, not all enlarged hearts are a good thing. There's also pathological hypertrophy, like in hypertrophic cardiomyopathy. This condition often is inherited, leads to thickened heart walls that can disrupt blood flow and electrical conduction. Unfortunately, it's sometimes undiagnosed until it causes a serious event, even in young and seemingly healthy individuals. So while the enlarged heart can be a sign of training or trouble, it's important to understand the context, and that's why we study both normal anatomy and the variations that can impact health. One of the most fundamental concepts of cardiovascular anatomy is the heart serves as a double pump, dividing circulation into 2 distinct but connected circuits, the pulmonary and systemic circuits. The right side of the heart handles the pulmonary circuit. It receives deoxygenated blood from the body and pumps it into the lungs via the pulmonary trunk and arteries. In the lungs, gas exchange occurs. Carbon dioxide is released and oxygen is absorbed. The newly oxygenated blood returns to the left atrium via the pulmonary veins. The left side of the heart takes over from here and drives the systemic circuit. It pumps oxygen-rich blood through the aorta and to the entire body, from your brain to your toes. As the blood moves through the systemic capillaries, it drops off oxygen and nutrients to pick up waste and carbon dioxide. The deoxygenated blood returns to the right atrium via the superior and inferior vena cava, and the cycle starts again. It's also very important to note an exception to the common rule. Normally, arteries carry oxygenated blood and veins carry deoxygenated blood, but in the pulmonary circuit, it is reversed. Pulmonary arteries carry deoxygenated blood to the lungs, and pulmonary veins return oxygenated blood to the heart. These 2 circuits work together to keep cells alive, delivering oxygen, removing carbon dioxide, and maintaining overall homeostasis. To understand how the heart is protected and structured, we need to look at both the pericardium and the 3 layers of the heart wall. Starting with the pericardium, this is a protective sac that surrounds the heart. It has 2 main parts. The fibrous pericardium is the outer layer and is made up of dense connective tissue that helps anchor the heart to the thorax and prevents it from overexpanding as it fills with blood. The serous pericardium lies beneath that. It's a thinner, double-layered membrane that produces lubricating fluid. The pericardial layer lines the fibrous pericardium, and the visceral layer, also called the epicardium, adheres directly to the surface of the heart. Between these two serous layers is the pericardial cavity, which contains serous fluid. This fluid allows the heart to beat with minimal friction, critical when considered how often the heart contracts each day. Now let's look at the actual heart wall. There are three layers. The epicardium is the outermost layer and is part of the pericardium. The myocardium is the thick muscular middle layer and one of the one responsible for pumping action. It's composed almost entirely of cardiac muscle. Finally, the endocardium is a thin, smooth inner layer made of simple squamous epithelium. It lines the heart chamber and is continuous with the inner linings of the blood vessels, helping blood flow smoothly and preventing clot formation. When we look closer at the myocardium, we see more than just a thick muscle layer. We see a very specialized design that makes the heart an incredible, efficient pump. Cardiac muscle fibers in the heart are arranged in a spiral or figure 8 pattern, especially around the ventricles. This arrangement allows the heart to connect in a twisting motion, which helps squeeze blood more forcefully out of the chambers with each beat. It's not just a squeeze, it's a wringing motion, kind of like wringing out a towel. This unique structure enhances ejection efficiency. Now let's look at the differences between the right and left ventricles. While both pump the same volume of blood per beat, they don't face the same resistance. The right ventricle sends blood to the lungs via the pulmonary circuit, which is relatively short and low pressure. As a result, the walls of the right ventricle are thinner. In contrast, the left ventricle must generate enough pressure to send blood through the entire systemic circuit, all the way to the brain, fingers, and toes. Because it faces greater resistance, the left ventricle wall is significantly thicker and more muscular. This structural difference is a great example of form following function. The heart adapts to design to meet the mechanical demands of each circuit, right side for volume, left side for pressure, and both sides must work together perfectly to keep the blood moving smoothly and continuously. Now that we've explored the heart's internal structures and muscular layers, let's turn our attention to the external anatomy, or what we would see looking at the surface of the heart. The heart has 4 chambers, the 2 atria on top and the 2 ventricles below. The atria are smaller and have thinner walls, acting mainly as receiving chambers. The ventricles, especially the left one, has a thicker muscular wall and functions as the main pumping chambers. Each atria has a flap-like extension called the auricle. These auricles slightly increase the volume of the atria and help accommodate more blood during the periods of high return, like exercise. You'll notice they resemble small ears, hence the name, which means little ear in Latin. From the anterior view of the heart, we can see most of the right atrium and right ventricle, while the posterior side reveals more of the left atrium and ventricle. This difference is due to the heart's slight rotation within the chest. Also prominent are the sulci, grooves on the heart surface that mark boundaries between chambers and house major blood vessels. The coronary sulcus runs around the heart and separates the atria from the ventricle, meaning the anterior and posterior interventricular sulcus mark the positions of the interventricular septum and contain the coronary arteries and the veins that supply the heart muscle itself. When we talk about the great vessels, we're referring to the large arteries and veins that directly connect to the heart, essentially the entry and exit ramps of the circulatory highway. Let's start with the pulmonary trunk. It arises from the right ventricle and almost immediately splits into the right and left pulmonary arteries, which carry deoxygenated blood to the lungs. This is one of those exceptions we mentioned earlier, arteries that carry deoxygenated blood. Once the blood has gone through gas exchange in the lungs, it returns to the heart via the 4 pulmonary veins, 2 from each lung, that empty into the left atrium. These are the only veins in the postnatal body that carry oxygenated blood. From the left ventricle, blood is pumped into the aorta, the largest and most muscular artery in the body. The aorta arches upward, then descends behind the heart, distributing oxygen-rich blood to every organ and tissue in the systemic circuit. The return side of circulation follows into the right atrium through the two major veins, the superior vena cava, which drains blood from the head, neck, upper limbs, and chest, and the inferior vena cava, which returns blood from everything below the diaphragm. Internally, the heart is divided into four chambers: the atria on top and the ventricles on the bottom. The atria are the receiving chambers. They collect blood coming back into the heart, while the ventricles are the pumping chambers that send blood out to either the lungs or the body. To keep the blood moving in the correct direction, the chambers are separated by walls called septa. The interatrial septum divides the left and right atria. It contains a small depression called the fossa ovalis, which is the remnants of the fetal opening, the foramen ovale, that allows blood to bypass the lungs before birth. The interventricular septum separates the left and right ventricles. It's much thicker and much more muscular because of the high pressure generated by the ventricles. The atrioventricular septum separates the atria from the ventricles and houses the valves that regulate blood flow between them. These valves are essential for maintaining unidirectional flow. The AV valves, like the tricuspid valve on the right side and the bicuspid or mitral valves on the left side, allow blood to flow from the atria to the ventricles but prevent backflow during ventricular contraction. They are anchored by chordae tendineae, which are strong fibrous cords attached to papillary muscles inside the ventricles. When the ventricles contract, these muscles pull on the chordae to help hold the valves flaps shut. At the exit of the ventricles are the semilunar valves, the pulmonary valve, and the aortic valve on the left. These prevent blood from flowing backwards into the heart once it has been pumped into the major arteries. Together, the internal chambers, septa, and valves work in perfect synchrony to keep blood moving forward efficiently and without backflow. Now let's take a closer look at each of the four chambers of the heart, starting with the atria. The right atrium serves as the receiving chamber for the deoxygenated blood coming from the body. It receives blood from the three major vessels, the superior vena cava, inferior vena cava, and the coronary sinus, which drains blood from the heart wall itself. Inside the right atrium, you'll find the fossa ovalis, the remnants of the fetal foramen ovale. The anterior wall and the auricle of the right atrium contain pectinate muscles, which are ridges of myocardium that help with contractions. From there, blood flows into the right ventricle, which pumps blood through the pulmonary valve into the pulmonary trunk, and on top to the lungs. The right ventricle contains trabeculae carnae, which are irregular ridges on the inner surface of the muscle wall, as well as papillary muscle and chordae tendineae that support the tricuspid valves during contraction. The left atrium receives oxygenated blood from the lungs through four pulmonary veins, two from each lung. Its walls are generally smooth, except for the auricle, which contains pectinate muscle ridges. Blood then flows into the left ventricle, the most powerful chamber of the heart. It pumps blood into the aorta through the aortic valve to be distributed to the entire body. The left ventricle has the thickest myocardial wall because it must generate enough pressure to push blood through the systemic circuit. Like the right ventricle, it also contains trabeculae carnae, papillary muscle, and chordae tendineae, but all are more robust due to the greater forces involved. Valves are critical to the heart's function because they ensure one-way blood flow and prevent backflow during each cardiac cycle. Let's start with the atrioventricular valves. The tricuspid valve is located between the right atrium and the right ventricle, and the mitral or bicuspid valve is between the left atrium and the left ventricle. These valves open during atrial contraction, allowing blood to flow back into the ventricles, and then close during ventricular systole to prevent blood from moving backwards. To help them stay shut under pressure, each AV valve is connected to chordae tendineae, which are anchored to papillary muscle in the ventricular walls. When the ventricles contract, the papillary muscles also contract, tightening the chordae to prevent valve prolapse. Next are the semilunar valves. The pulmonary valve controls blood flow from the right ventricle into the pulmonary trunk, and the aortic valve flows from the left ventricles into the aorta. These valves do not have chordae or papillary muscle. Instead, they consist of three pocket-like cusps that will fill with blood and close when pressures in the arteries exceeds that in the ventricles during diastole to prevent backflow. All four valves are supported by a structure called cardiac skeleton, a dense ring of connective tissue. It serves several purposes. It reinforces the valve's openings so they don't overstretch. It anchors the heart muscle, giving something solid to pull against. And importantly, it acts as the electrical insulation between the atria and the ventricles. This ensures that the atria contract first, following the ventricles, allowing coordinated pumping. Together, the valves in the cardiac skeleton work both mechanical and electrical regulators essential to each heartbeat. Let's talk about the step-by-step process that blood takes throughout the heart, which is a vital process that happens nonstop about 100,000 times a day. It all begins with deoxygenated blood returning from the body. Blood from the upper body enters the right atrium via the superior vena cava. Blood from the lower body enters through the inferior vena cava, and blood from the heart's own tissues enters through the coronary sinus. From the right atrium, blood flows through the tricuspid valve into the right ventricle. When the right ventricle contracts, it sends the blood through the pulmonary valve into the pulmonary trunk, which splits into the left and right pulmonary arteries. These arteries carry blood to the lungs. In the lungs, gas exchange takes place. Carbon dioxide is released and oxygen is absorbed. Then oxygenated blood returns to the heart via the four pulmonary veins from the left atrium. From the left atrium, blood passes through the mitral or bicuspid valve into the left ventricle, the strongest chamber in the heart. The left ventricle contracts and sends blood through the aortic valve into the aorta, launching it into the systemic circulation to deliver oxygen and nutrients throughout the body, and then the cycle starts all over again. Now let's take a closer look at cardiac muscle by focusing on its unique structure. The muscle cells of the heart are called cardiomyocytes, and while they share some features with both skeletal and smooth muscle, they also have very distinct characteristics suited for heart's function. Cardiac muscle cells are shorter and narrower than skeletal muscle fibers, and instead of being long, unbranched cylinders, they are branched and have interconnected. Most cardiomyocytes have one centrally located nucleus, though some have two. Like skeletal muscle, cardiac muscle is striated, meaning it has a banded appearance due to the organized arrangement of its sarcomeres, the contractile units of the muscle. Cardiomyocytes are packed with mitochondria, making up roughly 25 to 30% of the cell's volume. This reflects the heart's enormous energy demand and reliance on aerobic metabolism. These cells also contain stores of myoglobin, glycogen, and lipid droplets, which serve as the internal energy and oxygen reserve. Now let's talk about some of the difference between skeletal muscle. The T-tubules, which help propagate electrical signals into the anterior of the cell, are located at the Z-discs in cardiac muscle, rather than an A to I junction as in the skeletal muscle. Also, the sarcoplasmic reticulum in cardiac muscle is relatively underdeveloped. It does not store much calcium, so most of the calcium needed for contraction comes from the extracellular fluid. This slows the onset of the contraction compared to skeletal muscle. The structure supports its continuous rhythmic and involuntary contractions of the heart wall and is built to never stop. The unremarkable resistance to fatigue thanks to its metabolic adaptations. One of the most defining features of cardiac muscle tissue is the presence of these intercalated discs, which are specialized structures found only in the heart. These discs form the junctions between adjacent cardiomyocytes, and they are absolutely essential for both mechanical integrity and electrical coordination of the myocardium. Intercalated discs are composed of three main types of junctions. Desmosomes, which act like molecular rivets. They hold cells tightly together, especially important when the heart contracts with such great force and contracts over and over. Fasciae adherens, which are anchoring sites or acting filaments from the sarcomere attach to the cell membrane. This helps the force of contraction to be transmitted directly from one cell to the next. And the most important before coordination, we have gap junctions. These are channels that allow ions to pass directly from the cytoplasm of one cell to the next. This enables the electrical impulse, specifically the depolarization wave, to spread quickly and uniformly throughout the heart. Because the heart's muscle fibers are short and branched, the force of contraction is not transmitted to the tendon or the bone, as in skeletal muscle. Instead, each cell pulls on its neighbor and ultimately on the cardiac skeleton, a dense connective tissue framework within the heart. The intercalated discs are what makes synchronized contraction possible. Without them, the atrium and the ventricles couldn't contract in the coordinated way, and blood would not be pumped efficiently. These structures ensure that, despite being individual cells, cardiac muscle functions as a single unit, a unifying unit, a concept called functional synthesis. In the heart, there's two major types of cardiac muscle cells, each with a distinct role in maintaining the rhythm and function of the organ. The first, myocardial contractile cells, which make up about 99% of the heart's muscle cells. These are the workhorses of the heart. They contain sarcomeres that are located within the mitochondria and are responsible for the strong, coordinated contractions that push blood through the chambers and into the circulatory system. The remaining 1% are myocardial conducting cells, also known as the pacemakers or nodal cells. These are smaller and contain fewer contractile elements. Their main job is to not contract but to generate and conduct electrical impulses that tell the contractile cells when to contract. These cells are concentrated in specific areas like the sinoatrial node, atrioventricular node, and the Purkinje fibers. One of the most remarkable properties of cardiac muscle is autorhythmicity, the ability of the heart to generate its own electrical impulse. Even if the nerve input were cut off, the heart would continue to beat on its own thanks to the conducting cells. However, the autonomic nervous system, the sympathetic and parasympathetic divisions, and the endocrine signals like epinephrine can modulate the heart's rate, depending on the body's needs. Unfortunately, when the cardiac cells are damaged, such as during a heart attack, they do not regenerate well. Instead, the dead cells are replaced by fibrotic scar tissue, which do not contract. These reduce overall conduction function. There's promising research into cardiac stem cells, which allow some potential for regeneration. However, while cells grow in lab conditions can beat, most in vivo regeneration is still non-functional or minimal. Scientists have continued to explore ways to enhance repair and regeneration after cardiac injury, which could greatly improve outcomes for millions of patients. Let's finish this section by looking at the conducting system of the heart, the built-in wiring that keeps your heartbeat coordinated and efficient. It all starts at the sinoatrial node, located in the posterior wall of the right atrium, near the opening of the superior vena cava. This small cluster of conducting cells has the highest natural rate of depolarization, which is why we call it the pacemaker of the heart. It initiates the electrical signal that starts each heartbeat. From the SA node, the impulse spreads across the atrial wall thanks to gap junctions in the intercalated discs, causing the atria to contract and push the blood through the ventricles. The signal then reaches the atrioventricular node, located at the lower part of the right atrium near the septum. The AV node delays the impulse briefly. This is critical because it gives the ventricles time to fill with blood before they contract. Without this pause, the timing would be off and the heartbeats would pump efficiently. From the AV node, the signal travels down the atrioventricular bundle, also known as the bundle of His, which enters the interventricular septum and then splits into the right and left bundle branches. These branches run towards the apex of the heart, where they connect to the specialized network of fibers called Purkinje fibers. These fibers rapidly distribute the impulse upward through the walls of both ventricles, triggering the powerful and unified ventricular contraction that pumps blood to the lungs and to the body. This entire sequence, SA node to AV node to bundle branches to Purkinje fibers, ensures the heart's contraction in a specific order. First the atria, then the ventricles. This coordination is absolutely essential for efficient blood flow and has made it possible by both specialized conducting cells and the electrical connectivity between regular cardiac cells via gap junctions. Let's begin by zooming out and understanding what we mean by the cardiac cycle. This term describes one complete heartbeat, including all electrical and mechanical events that occur in the heart as it contracts and relaxes. The cycle is made up of two main phases. Systole, when the heart contracts and to pump blood forward, and diastole when the heart relaxes and fills with blood. Each cycle includes activity from both the atria and the ventricles. For example, first, the atria contract, known as atrial systole, pushing blood into the ventricles. Then the ventricles contract, ventricular systole, ejecting the blood into the pulmonary trunk and the aorta. After that, the entire heart relaxes during diastole so that the chambers can refill and process can be restarted again. At normal, resting heart rate is about 75 beats per minute. Each cardiac cycle lasts roughly 0.8 seconds. What's remarkable is how well timed these movements are, and they're all driven by the heart's own built-in electrical system. This conduction system ensures that the atria and ventricles work together in a coordinated rhythmic fashion. We can actually record and monitor the electrical parts of this activity using an electrocardiogram, or EKG. While the EKG does not directly show the heart's contraction, it reflects the electrical impulses that trigger those contractions. So, in summary, the cardiac cycle is the heartbeat in action. Electrical signals initiate contraction, valves open and close, blood moves from one chamber to the next, and the cycle resets, seamlessly and automatically, thousands of times per day. Now that we understand the big picture, let's break down the three major phases of the cardiac cycle. We start with atrial systole, which occurs just after the P wave on the EKG. This is when the atria contract, pushing a final volume of blood, about 20 to 30%, into the already partially filled ventricles. It's a brief phase lasting only about 0.1 seconds. Then we move into ventricular systole, which is triggered by the QRS complex. Here, the AV valves, tricuspid and mitral valves, slam shut to prevent the backflow of the atria. This produces the first sound, the love sound. The ventricles then contract, forcibly pushing blood out through the aortic and pulmonary semilunar valves into the major arteries. This phase lasts roughly 0.3 seconds. After, we finally enter diastole, the longest phase at approximately 0.4 seconds. It begins after the T wave, which marks the repolarization or electrical resetting of the ventricles. As the ventricles relax, the semilunar valves close, producing the familiar dub sound of the second heart sounder S2. This is when the heart is in its recovery phase and all chambers are relaxed and filling passively with blood from the veins. Each of these mechanical phases is tightly linked to the electrical events we see on an EKG, and those connections are key to understanding both normal function and many cardiac disorders. Now let's focus on the EKG, or electrocardiogram, one of the most important tools in cardiology. The EKG is a visual representation of the electrical events that occur in the heart. These electrical changes precede and initiate the mechanical contractions that we talked about earlier. We begin with the P wave. This small, rounded wave represents atrial depolarization. In other words, the electrical activity that causes the atria to contract. This happens right before the atrial systole. Next comes the QRS complex. This is a sharp, tall spike that represents ventricular depolarization. It's much larger than the P wave because the ventricles are bigger and more muscular. This complex triggers ventricular systole, the powerful contraction that pumps blood into the pulmonary and systemic circuits. Now, although the atria are also repolarized, meaning reset their electrical charge, atrial repolarization is not visible on an EKG. Why? Because it occurs at the same time as the QRS complex and gets buried beneath the large wave. Finally, we have the T wave, which shows ventricular repolarization. That's the recovery phase, leading to ventricular diastole when the ventricles relax and fill with blood. Clinically, the EKG is incredible and useful. It allows us to monitor heart rate, detect abnormal rhythms, assess for conduction blockages, or even identify myocardial infarctions or electrolyte imbalances. It's a non-invasive window into the heart's internal electrical wiring and a vital tool for diagnosing and monitoring. Let's bring it all together. The EKG isn't just a graph, it's a real-time map of the heart's electrical activity, and that electrical activity is what initiates the mechanical events of the cardiac cycle. The P wave marks atrial depolarization, which immediately leads to atrial systole. The atria contract to push blood into the ventricles. The QRS complex marks ventricular depolarization, leading to ventricular systole. This is when the AV valves close, creating the first heart sound, the lub sound. Then we get to the T wave, showing ventricular depolarization, which signals the start of ventricular diastole. At this point, the semilunar valves close, producing the second heart sounds known as the dub sound. You can think of the EKG as your GPS for the heart. It tells you what's happening, where and when. Clinically connecting EKG to the phases of the cardiac cycle help us diagnose conditions like arrhythmias, where the timing is off, heart blocks, where signal transmission is delayed or blocked, myocardial infarctions, where part of the heart muscle dies and shows up as a ST segment changes, and even valve problems, which can either alter the timing and the sounds of the heartbeat. So the EKG isn't just for cardiologists, it's a foundational for everyone in healthcare working with the cardiovascular system. Let's take a moment to appreciate just how demanding the heart is as an organ. It's not only the hardest working muscle in the body, it's also the one that never gets to rest. The heart beats over 100,000 times a day, so that the cardiac muscle cells or cardiomyocytes need a constant and abundant supply of oxygen and nutrients to function properly. That is where the coronary circulation system comes in. This is the heart's own dedicated vascular network. It includes coronary arteries, which bring in oxygen-rich blood, and coronary veins, which carry away deoxygenated blood from the waste products. But here's something unique. Blood flows in the coronary vessels isn't continuous, it's actually phasic, meaning that it changes depending on whether the heart is in systole or diastole. The best blood flow occurs when the heart is relaxed, during diastole, because the muscle isn't compressing on the vessels. During diastole, especially in the left ventricle, the strong contraction compresses the coronary arteries and reduces flow. Because of this and the heart's high metabolic demand, even a short disruption in coronary circulation can result in ischemia, which is a reduction of blood supply, and eventually hypoxia, or oxygen deprivation. If prolonged, this can lead to death of cardiac tissue, known as a myocardial infarction or a heart attack. Now let's look more closely at the arterial supply of the heart, which begins right at the base of the aorta. Immediately after it exits the left ventricle, the left coronary artery, or LCA, quickly branches into the two major arteries. The first is the anterior interventricular artery, most commonly known as the left anterior descending artery, or the LAD. This vessel runs down the anterior surface of the heart in the interventricular sulcus and supplies blood to the anterior portions of both ventricles and the interventricular septum. It's often called the widowmaker because blockages here are particularly dangerous. The other branch of the LCA is the circumflex artery, which curves around the left side of the heart in the coronary sulcus. It supplies the left atrium and the posterior wall of the left ventricle. On the right side, we have the right coronary artery, or RCA. It travels along the right coronary sulcus and sends off two major branches: the marginal artery, which serves as the lateral side of the ventricle, and the posterior interventricular artery, also known as the posterior descending artery, the PDA, which supplies the posterior portion of both ventricles and part of the interventricular septum. These coronary arteries form small anastomoses, which are natural connections between the branches, which can sometimes provide alternate pathways if one route is blocked. However, these connections are typically too small to compensate fully during the blockage, so the area downstream still becomes ischemic, leading to death of the cell and potentially a heart attack or a myocardial infarction. Just as the myocardium needs a steady supply of oxygenated blood, it also needs an efficient system to drain away deoxygenated blood and waste products. That's the job of the coronary veins. There are three main cardiac veins that are parallel to the arteries and collect most of the blood that is used by the heart muscle. The great cardiac vein runs alongside the anterior interventricular artery, or LVA, on the front of the heart. It gathers blood from the anterior regions of the heart. The middle cardiac vein travels with the posterior interventricular artery and drains the posterior part of the heart. The small cardiac vein follows the right coronary artery and handles drainage from the right side of the heart. These veins all feed into large structures called the coronary sinus, which is like a collecting reservoir on the posterior side of the heart, nestled in the atrioventricular sulcus. The coronary sinus empties directly into the right atrium completing the loop of circulation. An exception to this rule is the anterior cardiac vein, which drains to the anterior surface of the right ventricle. These veins bypass the coronary sinus altogether and connect directly to the right atrium. Let's talk about one of the most critical clinical aspects of coronary circulation: atherosclerosis, the primary cause of coronary artery disease and myocardial infarctions, what we often call a heart attack. Atherosclerosis is a slow, progressive condition where plaque, a thick, fatty deposit made up of cholesterol, lipids, immune cells, connective tissue, and even smooth muscle cells, build up inside the walls of the coronary arteries. Over time, these plaques narrow the lumen of the arteries and reduce their flexibility and ability to dilate. This narrowing leads to ischemia, a lack of sufficient blood flow to the myocardium, and eventually hypoxia, a shortage of oxygen in the tissues. This can cause angina pectoris or chest pain, especially during exertion when the heart needs more oxygen. If the blockage becomes severe or sudden, the affected areas of the heart muscle can die, resulting in a myocardial infarction. Diagnosing myocardial infarction involves several methods. An electrocardiogram looks at the electrical changes in the heart. Blood tests for enzymes like troponin and CKMB reveal muscle cell damage. Coronary angiography shows locations and severity of blockages using dye and imaging. Treatment depends on the severity, and that can include lifestyle changes like improved diet and exercise, medications to lower blood pressure, reduce cholesterol, or prevent clotting, angioplasty, where a balloon catheter opens the coronary artery, often followed by a stent to hold it open. Coronary artery bypass grafts, or CABG, where a vein from another part of the body is grafted to bypass the blockaged artery. Risk factors are largely preventable and include smoking, poor diet, sedentary lifestyle, obesity, high blood pressure, diabetes, and high LDL cholesterol. Genetics and age also play a role. Understanding this process not only gives us insight into how coronary circulation works, but also why it's important to maintain cardiovascular health throughout life. Now let's begin talking about one of the most remarkable and foundational sections in cardiac anatomy: the development of the human heart. This is an especially fascinating topic because the heart is the first functional organ to develop in the embryo. It begins to beat and pump blood by day 21 or 22, just 3 weeks after fertilization. That's incredible when you consider the size and complexity of the organ and about its form. Our discussion will explore how the heart originates from the specific region in the mesoderm called the cardiogenic area, and how it develops through a series of steps that include the formation of 2 endocardial tubes, their fusions into a single primitive heart tube, and the formation of 5 primary regions. But we won't stop there. We'll also track how these regions give rise to the 4 chambers and the great vessels of the mature heart, and how the organ structure folds and reshapes itself through the process called cardiac looping. This is not just the development lesson. Understanding this process gives you the insight into the congenital heart defects, fetal circulation, and a timeline of embryonic development. Let's dive into how the heart actually starts forming into the embryo. Around day 18 to 19 after fertilization, a region called the cardiogenic area forms in the mesoderm, one of 3 primary germ layers. This area is located near what we call the head of the embryo. The heart forms early and high up because of how critical and crucial it is to early survival and nutrient distribution. Under the influence of signaling molecules from the endoderm, 2 strands called cardiogenic cords begin to take shape. These cords quickly hollow out, creating paired endocardial tubes, essential the foundation of the heart. By day 21, those tubes fuse together into the midline, forming a single primitive heart. This heart tubes then starts to specialize into 5 distinct regions, arranged from top to bottom: the truncus arteriosus, which eventually becomes the aorta and the pulmonary trunk, the bulbus cordis, the primitive ventricle, the primitive atrium, and the sinus venous, which essentially receives all venous blood. Interestingly, in this early stage, blood flows in the opposite direction compared to the adult heart, from the sinus venous into the truncus arteriosus. This setup is temporary but essential. It sets the stage for the next major steps, including looping chambers formation and valve development, which we'll see in the next slide. Now let's explore how these 5 primitive regions we talked about in the last slide actually turned into the structures of the adult heart. The truncus arteriosus divides into the ascending aorta and the pulmonary trunk, forming the 2 great arteries that leave the heart. The bulbus cordis becomes the right ventricle. The primitive ventricle forms the left ventricle. The primitive atrium gives rise to the anterior walls of both atria and the auricles, those small muscular flaps. Lastly, the sinus venous becomes part of the posterior wall of the right atrium and eventually contributes to the development of the sinoatrial node, which is crucial for heart rhythm, as well as the coronary sinus. Around day 23, the heart tube folds into an S shape, a critical step in correctly aligning the atria above the ventricles and establishing the final topography of the heart. Finally, from weeks 5 through 9, we see the formation of the interatrial and the interventricular septum, which divides the chambers. This is also when the atrioventricular valve and the semilunar valves develop. And although the heart now resembles an adult heart, fetal shunts like the foraminal valley and the ductus arteriosus stay open to allow blood to bypass the non-functional fetal lungs. These shunts normally close at birth or shortly after, once the baby starts breathing on its own. This transformation from simple heart tube to a fully developed 4-chambered organ is one of the most complex and beautiful processes in embryology.